Okay, so welcome to our Wednesday night professional development presentation. This is a Wednesday, February 12th, and we are honored to have Anna Pelleboer.
Pelleboer, yeah.
Oh, close. Anna took THMA, I'm going to guess 4 years ago,
Yeah, it's about that.
about 4 years ago. Took THMA, and she's been a huge advocate of THMA, so thank you. And Anna is the co-founder, and a board certified primary care nurse practitioner, brings over a decade of nursing experience to the team at Cambridge Skin and Wellness in Cambridge, Ontario. She is dedicated to continually advancing her aesthetic skills. Anna offers customized treatment plans to her patients and is lauded for her kindness, and she is very kind, inclusivity, and attention to detail in providing subtly rejuvenated natural results. So thank you, Anna, for sharing all your information on acing acne in primary care.
Thank you so much for that introduction. And yeah, it's hard to believe it's been 4 years. I'm so glad, I met you, Tracy, and I applaud you and always look up to you and everything that you do for our profession. So yeah, I guess today we'll talk about acne management. I'm Anna, and I have no conflicts of interest or disclosures. Just a passion for skincare and managing acne, which is pretty common and prevalent in a lot of patients that we see. So just a little bit of background and epidemiology. It affects about 85% of young adolescents ages 12 to 24, and then persists in about 30% of our patients in their adulthood. It is more common in females. There's a genetic link, and you can get into it and ask your patients about a little bit about their family history. You can ask about other conditions and symptoms, so things like PCOS or polycystic ovarian syndrome, hyperandrogenism, and hypercortisolism, precocious puberty, or chromosomal abnormalities. I put acne cosmetica here because it's probably a lot of the patients that we see. They are using so many different products on their skin. They might be going to Sephora, The Ordinary, Korean skincare, a lot of things that honestly myself, I get overwhelmed when they bring their bag of goodies in. But a lot of times they can be using a lot of things that might actually be triggering their acne. So it's always better to review those things. Medications, things like lithium, steroids, progesterone, a lot of these they have to stay on. But if your patient has acne and you ask them about an IUD that's progesterone only, or maybe they have a Nexplanon, which is the implant, progesterone implant in their arm, those will definitely cause acne in a large portion of our patients. So that's something simple that they can have managed. Pathogenesis. So we know that acne is a chronic inflammatory skin disease of their pilosebaceous unit. It presents with open and closed comedones, papules, pustules, nodules, and or cysts in their face or their trunk. And there's usually erythema, pain, pigmentation, specifically post-inflammatory hyperpigmentation, and scars, not to mention reduced quality of life and mental health implications such as depression. It's multifactorial, so there's follicular hyperkeratinization, microbial colonization with C. acne, sebum production, complex inflammation, neuroendocrine mechanisms, and genetic as well as non-genetic factors. Assessment, you want to ask them about, where they have acne, what type of acne lesions, what things they've tried in the past, occupational, recreational factors such as sport gears or greases, clothes that they're wearing that might be really tight and causing some acne as well. Medications, the impact of their acne on their quality of life, and you can get really technical and do some tools, which I honestly never do, just because it's not needed. If they have acne, especially if it's moderate to severe, they're struggling with it and they'll want to talk about it. But they don't always talk about it. They might see you for their neuromodulator and they'll have an acne flare, but they just are not talking about it. But you can ask them, even, even if you're not prescribing medications, you can certainly talk to them about this and write down recommendations and ask them to bring it to their primary care provider who can prescribe things. You want to ask them about picking habits. If they're popping pimples, picking at scabs, you definitely want to discourage it because that will cause PAH and scarring. And again, symptoms of hormonal imbalances. Investigations are not needed unless you're worried about some endocrinological disorders like polycystic ovarian syndrome, if they have irregular periods, androgenic alopecia, high blood pressure, obesity, infertility, then their primary care provider can order a bit of a workup, mostly just to rule out other disorders. There are two sets of guidelines that I personally follow and most of us in primary care like to refer to. There's the American Academy of Dermatology, and then we have Canadian guidelines. The current guidelines in Canada are quite old. They're from 2016, but the 2024 guidelines are just being finished, so those will be out as well. Both are great. They're just missing some of our newer medications that are now available. Types of acne. So we've got our mild acne. I would say I see a lot of mild acne cases, and you might too in your chair, but patients may not really mention it, or maybe they do mention it. I typically ask them, I say, hey, I'm noticing some of these breakouts. Is it okay if I talk to you about your acne today? They might not notice it. They might feel like they don't want to talk about it, but you can certainly bring it up just because you'll have some tools to offer for them. Moderate acne, those patients usually do come in. Severe acne, again, those patients often do come in to talk about those things. Cystic nodular acne and acne condyloblata and acne fulminans, I only see because I'm in a dermatology setting. These are really severe cases. They do need isotretinoin or Accutane. And I usually get patients to see dermatology for those two, just because even if you're comfortable prescribing isotretinoin, there needs to be other management. Sometimes you put patients on steroids, sometimes they need injections, incision and drainage. It's just really complicated, so I usually defer that to dermatology. For mild acne, usually I'll always have them on a retinol unless there's a contraindication, but you can consider a combination treatment such as benzoyl peroxide, clindamycin, erythromycin, or topical that has both. The only contraindications really would be, I guess, allergy, but that's super rare for retinols. And redness and irritation and skin peeling is not an allergy. It is a reaction to retinols, and I'll talk about how to mitigate those side effects. But retinols are really contraindicated if your patient is pregnant or breastfeeding. They may benefit from an antibacterial cleanser, but avoid excessive washing because that will stimulate oil production. And non-soap cleansers are better tolerated. So things like CeraVe, Cetaphil, La Roche-Posay are over the counter, but if you're working with a medical grade skincare line, you can certainly recommend those because they'll be formulated specifically for your acne-prone patients. You can suggest a salicylic acid cleanser for added benefit, and just talk about oil-free skincare products, moisturizers, and sunscreen. The 4 retinoid options that you can write down for your patient or prescribe to them are things like tretinoin. Stevia A is actually on back order, so that one's not really an option, but some pharmacies are still carrying it. Araslo is the one I prescribe the most, I would say. It is the most potent retinoid, and it is covered under ODB, the Ontario Drug Benefit Program. And so if your patient's under 18, that's perfect because that will be covered. Aclef or trifurtine is in theory a highly selective retinoid, and so it's supposed to be less irritating, and it's the only one that is studied for truncal acne and was found to be effective. In practice, I don't find that patients say that it's less irritating. They still find it just as irritating as any potential other retinoid. Adapalene is diferin, and it comes in two different strengths, tends to be the best tolerated retinoid. There is no comparative data to date that demonstrates that one is superior to another, so you can really try any of these. I just prescribe Eraslo, I think, out of habit, but also because it's covered. And then, like I said, main concern or side effect, irritation and erythema. For mild to moderate acne, I usually do suggest a combination medication, but you have different options. You can also suggest a benzoyl peroxide. I usually don't suggest anything higher than 5% because there's no evidence that higher formulations are more effective, but they definitely will cause more irritation. And so that decreases their tolerance and ability to comply with the medication. You would want to warn them that benzoyl peroxide, which is over the counter, may bleach their hair or clothes or their pillowcase, just to give them a heads up. So maybe just having them use a white pillowcase, or if they don't care, they might say it's fine, it doesn't matter. Salicylic acid is over the counter and is available as a wash. It does have antimicrobial and keratolytic effects. Azelaic acid, this would need to be prescribed, but it's really good for patients who have post-inflammatory hyperpigmentation or blemishes because it has like a lightening effect to it. And it is one that is actually pregnancy safe. So if your patient is pregnant, they can use azelaic acid for acne management. Retinol, always. I always have a retinol on board. I guess the only time is if it's contraindicated. Plus, our patients benefit from it in terms of uneven skin tone, collagen induction, and fine wrinkles. The topical antibiotics, there's a few that are available. Clindamycin is one, erythromycin, which is actually safe in pregnancy as well. Dapsone, it has good tolerability and it's good for sensitive skin. And there's no evidence that any antibiotic is superior to another. Just remember, if you're recommending an antibiotic, always pair it with a benzoyl peroxide because you want to ensure that there is no antibiotic resistance. The other option is clascoterone, which is Winlevi. It's a great topical. I use it very often for patients, especially women who are in their 30s who are getting a lot of hormonal acne, maybe acne flares around their period. It is the first topical androgen receptor inhibitor, and it's approved for 12 plus, male and female. They apply it twice a day, morning and evening. You can pair it up with a topical retinoid at nighttime. Only downfall is it's not covered by the Ontario Drug Program, and it's about $300 for 12 weeks. However, most private plans will cover this. I created this chart because I thought this was a good way to remember what the different classes do. So you can take a picture of it or save it if you find that's helpful. If you're seeing specific things or specific symptoms in your patients, you can refer to this just to help you make a decision. And then this is, again, another table I put together for combination treatments. So you have your prescription combos, so retinoid and benzoyl peroxide. There's Tactopump with 2 different strengths. I usually start with the lower strength just because I want them to tolerate it. Or if they've tried it before and they had some benefit, but not quite, you can always go up with the adapalene, which is the retinoid portion. Retinoid and antibiotic combo is Biacna. If you are prescribing this, remember they need a benzoyl peroxide on top of this because you want to, again, avoid antibiotic resistance. Antibiotic and benzoyl peroxide combinations, we have benzaclin and clindoxil. And then the newest member it's really a great medication in which I now started prescribing. It's indicated for moderate to severe acne. I think it just got approved maybe two 2 or 3 months ago. And it's a retinoid, benzoyl peroxide, and an antibiotic. So it's clindamycin, adapalene, and benzoyl peroxide. In the trials, 50% of patients had near clearance at 12 weeks, 75 to 80% noted improvement in inflammatory pustules and papules, and 75% noted improvement in comedonal lesions. And just similar, you would think it's more irritating because it has all three, the antibiotic, the benzoyl peroxide, and retinoid, but actually it was just similar to other combination treatments. Moderate to severe acne. So usually in these patients, if they're not opposed to it, I will suggest an oral antibiotic. You can use either doxycycline or minocycline. Just because of tolerability and potential side effects, I do recommend doxycycline over minocycline, and you would prescribe it for 12 to 16 weeks, letting your patient know that they probably will notice most improvement at the 3-month mark. So just not to give up on it. For doxycycline, I'll usually start at 50 to 100 milligrams, and I'll usually just use the immediate release once a day. If they're very sensitive, you can use an extended release tab and just use the 40 milligram once a day tablet. You can consider using Septra as well if they're allergic. And remember, again, to not use as monotherapy because you want to avoid antibiotic resistance. So ask them to use a 5% benzoyl peroxide gel in the morning. For female patients, you can consider combined oral contraception for anti-androgen effects. You can also consider spironolactone, 50 to 200 milligrams once a day. I'd probably start at 50 to 100. And you can reassure them if they go home and they start Googling, because there's some things that show that there was an increased risk of cancer in rats. There's actually no increased risk of any cancer in human studies, only rat studies where they were using 150 times the normal dose that we use in humans. And there's no need to monitor potassium unless there are risk factors. Topical glucocorticoid or Winlevi is also very reasonable. We talked about that as well. And you can consider a low dose of isotretinoin or Accutane for moderate acne if they have a wedding coming up or something really special, if they really want it gone, the acne gone a bit quicker. So isotretinoin, I usually will reserve for severe acne. And there's a few different formulations: Accutane, Claris, Epuris, and Absorica LD, which is the newest one. And it's a micronized dose. And it's actually better absorbed, and there's no need for food with that one. The way it works is it normalizes sebum production and abnormal keratinization, reduces inflammation, again, see acne. You would have to discontinue all other acne treatments. The cure rates are really high, about 89% at 20 weeks. You would start them at a lower dose, either 0.3 to 0.5 milligram per kilogram per day, divided twice a day for 4 weeks. And then you just increase as tolerated, but your goal is to be at 1 milligram per day, divided twice a day. You would continue for 1 to 2 months after remission has been reached. And the common side effects that you really want to talk to your patient about is skin and mucous membrane dryness, irritation, and photosensitivity. So really making sure that they're using their sunscreen and avoiding any chemical peels, microneedling, lasers for at least 6 to 12 months after Accutane. Usually 6 months should be sufficient. The more rare complications are, I listed them up below there, but they're pretty rare, but you'd want to have them on the consent form. I usually have a consent form if I'm starting patients on isotretinoin, and a handout of expected side effects and what to do. So dry mouth, what you can do about that, or photosensitivity, reviewing kind of regular use of sunscreen. Adverse effects that, again, are really rare would be dyslipidemias, increased triglycerides, pancreatitis, and hepatitis, and teratogenicity. So definitely they have to be on 2 birth control methods. One could be pharmacotherapy, and the other one would be use of a barrier method. And monthly pregnancy tests are recommended. So you want to make sure, like I said, obtain a consent before your treatment. It should be written that is also witnessed, and then have that in the patient's chart. You want to do 2 pregnancy tests within 30 days before the treatment is started, and then monthly during the treatment after completion. The fasting labs, they used to be very comprehensive. Now the recommended guidelines just say they need a fasting blood lipid panel and an ALT at baseline, which is a liver enzyme. And then 2 months after the peak dose is obtained, you can repeat those. And if normal, you do not need to continue monitoring. Old practice was monthly blood work, essentially. You should be doing monthly pregnancy tests. I will say that that practice varies among prescribers. Not everyone does monthly pregnancy tests. I think if you have a patient that understands and is very compliant, you can, depending on your comfort level, make a decision to do something different. But it is recommended to do monthly pregnancy tests. And assessing adherence to contraception. You want to assess their mental health before and at follow-up appointments. There was some concern about Accutane causing potential increased, depression cases or suicidality, but the latest data doesn't actually show an increased link to psychiatric disorders or inflammatory bowel disease, which again was one that there was some concern about this. But it's mostly just acne itself is linked to higher cases of depression and suicidal ideation. Once your patient is under control and off isotretinoin for 6 to 12 months, you can consider treatment of acne scars and post-inflammatory hyperpigmentation. So if you're offering things like microneedling and chemical peels, those are great to start working on scars and pigmentation, blemishes, uneven skin tone. Lasers such as a CO2 or an erbium, and intralesional steroid injections for nodules, and hydroquinone cream, 2 to 4% for post-inflammatory hyperpigmentation, but you have to limit the hydroquinone for 2, 3 to 4 months just to avoid permanent discoloration. Culture or not to culture. So in most cases, you don't need to culture any acne lesions, but if there are patients with eruptive uniform pustules, nodules, in periorificial areas, particularly in prolonged tetracycline treatment, they may benefit from a culture to diagnose a gram-negative folliculitis, and treatment should be guided by your culture and sensitivity. You may also consider culturing patients presenting with monomorphic truncal papules and pustules to diagnose a type of fungal folliculitis. And then again, you would treat based on your culture result. So I put the slide in here just to kind of go over things that I usually recommend for patients who are really sensitive to acne prescription medication, specifically retinols, retinoids. You may want to start with applying the medication once or twice a week in a thin layer, and let your patients know that if they can tolerate once or twice a week, you can increase it to every other day for a couple of weeks. If they can tolerate that, then daily application. You want to avoid application immediately after washing face. If you're very sensitive, avoid harsh cleansers, scrubs, consider soap-free cleansers. Use short contact applications. So if your patient can't tolerate a retinol, what you can ask them to do is apply it for at least 30 minutes and then wash it off and then work their way up to it. You would apply retinols at nighttime to improve adherence and irritation. Sunscreen, make sure that they're using their sunscreen and reapplying it every 2 hours. Treat small areas of skin first if they're very nervous, just to see the response, and reminding them to not lather their retinol all over. Using a small pea size is usually enough. You can consider the vehicle that you're prescribing. So gels tend to be more drying than lotions or creams, and avoiding thick oil, makeup, or skincare products. You can create a handout, which I mentioned already, just to help with common side effects and management, and also avoid multiple phone call follow-ups about every side effect. Acne in pregnancy, so there are very limited management options, but like I mentioned, azelaic acid by prescription is safe for pregnancy and breastfeeding. And it is quite effective. Response is seen as early as 4 weeks, but again, it can take about 2 to 3 months for any benefit to be noted. And that's really it for my presentation.
Thanks, Anna. Lots of information piled into that.
That's a lot, yeah.
There is a lot. Anybody have any questions? Did you talk about, which I'm sure a lot of people, oh, Robin says, can we see the last slide again?
Yeah, for sure.
Oh, with the references maybe.
Yeah, let me just, am I sharing it? Oh, I am sharing it, sorry. Can you see that?
Right. And I'm going to stop recording. So thank you. We'll continue on, but thank you.